Yeah, I think that last topic especially is something we haven't really visited often on this podcast, but it's such a huge slice of the healthcare spend and socially such a scary and difficult and expensive and estate wrecking expense. But that geriatric care and facility management, like if you can keep somebody adherent, if you can keep somebody um, on track and managing their disease states, if not defeating them, but at least, staying home and aging and their community. There's such a huge need for that on a healthcare spend, on a social spend, on a heartstrings pull, that in all of those areas. That really, I don't see that anyone but independent pharmacy can fill that. And so, how do you think that independent pharmacies can, really convey that value? Are there metrics or opportunities there?
I think that's the next frontier. I mean, I think that whole realm of the medical at home, and we're trying to figure out how to, you know, justify so we can get paid to cover those services. That because we're doing kind of the same services as we do in long-term care. However, I think the best places to go out and partner is with home health agencies, all right, that are trying to do the same thing, keep these people at home. Even group homes and personal care homes, which they're a lot of times based in that person's community. They can only take care of people if they can at least do the basic things. And if you can help identify. So for example, one of the things, and I know that we don't do this yet at Klingensmith, but in putting on my old geriatric hat is fall risk assessment. There are many medications can lead to falls. There's much data out there. If you're on two or more CNS type of drugs that cross the blood-brain barrier and get into your brain, you're at higher risk for fall. Somebody breaks their hip, all right, their life expectancy may be less than 5 years based on some of the data out there. So just identifying falls to be able to, the other thing is marketing it to caregivers such as family members. I had a great grandfather who lived 6 months shy of 100, and I had my other grandfather, pass away in his early 90s, and both of them lived at home pretty much until the end of their life. And my great grandfather slipped and fell, all right, and broke his hip, and kind of the trajectory of his last year and a half was, having to go to a home. And my grandfather hurt his back, but for a long time, they were able to stay at home because they had caregivers. They had somebody managing their medications and being able to do that. So, a son or daughter, if mom and dad lives in the same town with them or whatever, they would rather be able to go visit them at their house than, having to go to a nursing home, which that's not always the greatest environment to go visit a loved one. And sometimes they're isolated, things like that. So, I think doing that med rec, there's lots of programs. You don't have to go do a geriatric residency to be a geriatric whiz, but there's lots of programs of, identifying, there's, the Beers criteria, the stop criteria. They're not perfect, but they guide you of what are bad drugs that elderly people shouldn't be on. What are things that put them at risk for falls? Just getting them adherent. I think those things we could do well because we have that access point, for that. So, I speak passionately about it, but I know we could. And I know that from experience from what I've done in my residency, what I've done in geriatrics. And I always tell a story, and I did a CE at our state association on medical at home, because I think this is the next realm. And for the medical at home is what we were talking about earlier. You bring somebody on board, you do a good med rec, you look at their medication regimen, you simplify it. Ask the simple questions. Have you fallen in the last couple of weeks? When you fell, did you break anything in the last year? Do you get dizzy when you sit up? And then just look at their meds. And, there's
Sure.
enough software out there you can identify. But when I worked with the hometowns, we had a pharmacy resident. And this pharmacy resident, was working with this lady that was down the street, and she had some early dementia, but she could take care of herself. And we actually simplified her regimen. And we didn't have fancy adherence packaging then, but we actually had 7-day, pill containers, and
Mm-hmm.
we simplified it to morning and evening. And she and her daughter, who lived in California, kept wanting her to go to California, and she didn't want to. She wanted to live in her community. She went to her local church every day. She went to the senior center, and by doing adherence packaging, she stayed there for about 3 years. I don't have true scientific evidence that was it, but the community and her neighbor looked after her.
Yeah.
3 years later, she had to go to the she ended up flying out and living with her daughter. And I can remember this same resident actually worked for us, and she said, "You know what? I guess maybe we failed." I said, "No, we didn't fail. She got to live 3 years of good quality of life the way she wanted to live." And I think that's something that, all community independent pharmacists take pride in their communities. And I think that's something that's the next big area to do. And, the tools we have to be able to just putting people in adherence packaging facility, med syncing, they're all there for us to be able to take advantage of this.